Good evening and welcome to NRAS Live. My name's Clare. I'm Chief Exec of the National Rheumatoid Arthritis Society, and I'm delighted to be welcoming my two wonderful panellists this evening, Professor Sam Hider from Keele University and Dr Jacqui Clinch from Bristol, who's also the BSR Vice President. So you're both very welcome indeed, and it's great to have you on a summery the last of the summer wine, perhaps, August evening. Don't forget, if you've got any questions regarding the topic that we're going to be covering this evening, which is about research in both rheumatoid arthritis and in juvenile idiopathic arthritis, any questions relating to the topic, you can put it in. If you're watching on Facebook, you can put your comments in there. If you're watching on any of the other channels, you can also put your comments and ask questions. And we will try our best to cover as many questions as possible. We do have some already pre-submitted as well. So with no further ado, first of all, just like to say again, welcome to you both and thank you for joining. We're going to kick off with Sam, who's going to share a presentation about what the latest is happening in well, not the latest, but rheumatoid arthritis research, what it is, what sort of research is going on. And, and again, that may well prompt some of your questions. And then I'll be introducing Jacqui a little later on. So with no further ado, I'll hand over to you, Sam.
Thanks, Claire, and thanks for inviting me to give this presentation. I'll just wait for the slides to come up. Lovely. So I've entitled this Research for All, the what, the why and the how of clinical research for people with rheumatoid arthritis. And I guess to start with a disclaimer, I'm a researcher, so I'm a Professor of Rheumatology at Keele, but I'm also a consultant rheumatologist working with people with rheumatoid arthritis in Stoke-on-Trent. So I hope this evening just to demystify some of the jargon about clinical research. Researchers are terrible for using lots of long words and lots of very complex different statements. So I'm hoping to demystify what some of those things mean, talk a little bit about clinical research, a little bit about public involvement, talk about the different types of research. So I think often when we think of research, we think of clinical trials, but as researchers, we do a whole array of different research from interview studies to surveys. I'm going to talk a little bit about how research gets into practice, and then a little bit about how people who are interested can get involved in research and where you might be able to find out more. So clinical research is just a process to find better ways to understand, detect and treat health conditions. So obviously we're interested in RA tonight. And I just wanted to bring in the difference between clinical research, where people participate in a particular study. So you might sign up to fill in a survey about your arthritis or to do an interview with a researcher, versus what's known as public involvement. And public involvement is when members of the public who have lived experience of a particular condition get involved in designing, running and sharing research findings rather than directly taking part in the research themselves. And so there are different ways that one might get involved, either in taking part in a research study or being a public contributor to how research studies run. So when we think about research, as I say, often people think about research as being clinical trials, and that's obviously a very common form of research, but we also do a lot of other research as well, what's known as observational studies. And what do I mean by that? So a clinical trial, and when you think of a clinical trial, you might automatically think about drugs, but it's a way to study new drugs, devices, so things like splints or injections, or treatments. So you might want to think about exercise treatments, not just drug treatments, to see whether they're safe and whether they work in people. And often before a clinical trial can come to being undertaken, there's an awful lot of preclinical studies that happen first to develop a drug, to bring it to animal testing, to lab testing, to understanding that something's safe to use in humans before it gets to the point of a clinical trial, and certainly before it goes on to be approved as a regular treatment. So in clinical trials, people will often be what's known as randomized. And so that's put into a group by chance. And that's one of the things to think about if you're thinking about taking part in a research study, is that you may not know which treatment you're going to be allocated to. And effectively, that's often done by a computer. So usually for a drug trial, a treatment will be compared to the best standard treatment. Often in RA clinical trials, for example, treatments will be compared to how people would do on methotrexate or how people would do on a biologic. And when we think of clinical trials for rheumatoid arthritis, it's obviously the biologics trials that have really changed how we go on to treat people over the longer term. And clearly there have been a number of different biologics trials over the years, and there are trials ongoing still to work out which treatment people ought to be given first or second. But other trials that influence clinical practice are things like the hand exercise trial, which was published in The Lancet a few years ago and showed that hand exercises can have a long-term effect on people's function. So it's important to think beyond just drug trials. The other thing that researchers often talk about is what's called double blinding. So when we do a research study, knowing which treatment each person gets can affect the results of the study, and that's what's known as bias. So sometimes people sign up to take part in what's called a double blind study, and that's when neither the researcher nor the patient knows which treatment they've been given until after the study's ended. Obviously, it's difficult to blind some studies. So, for example, injection treatments are harder to blind. People may be given placebo injections. But again, if you're looking to take part in a research study, all of those things will be explained at the time. So by contrast to a clinical trial, an observational study is a study that collects health information about people, but without changing their medical care. And so data could be collected using surveys, so either questionnaires that are filled in on paper or these days online, interviews with people with a particular condition or a particular variant of a condition, or could be done by doing blood tests such as genetics or studies using synovial fluid, for example, or by reviewing medical records. And of course, one of the biggest observational studies that's had an impact on RA treatment is the Biologics Register. And that's been running now for over 20 years and has really shaped how we use a lot of the treatments these days in rheumatoid arthritis. So how does research get funded, get started? So ideas for important research questions can come from 2 or 3 different areas, really. One is where researchers can bid for to do a particular type of research to answer a question. So that's known as researcher-led research. Or sometimes some of the big research funders in the UK put out important questions that they want answered. And I'll give it, so one example of this is there's a study that I'll talk about in a minute about, which is a randomized trial of people who are taking biologics, where people are asked to sign up to either stop or continue their biologic when they're having orthopedic surgery. So that was what was known as a funder-led research. So that research study, the question that they wanted answering was put out to the research community, and then different research groups bid to answer that question. And researchers will have to submit a detailed research plan of how they want to do their research, things like how and where it'll be conducted, what are the impacts for people who have a particular condition, what are you asking people to do as part of the study, what are the risks and benefits, and increasingly, is it value for money? And sometimes this can be a 1 or 2 or even a 3-stage process, and proposals will be reviewed, feedback given, and this can take quite a long time. So often people are amazed when they get involved in the public involvement scope of these. So we might put in a research study perhaps in early March, for example. We'll get feedback quite a few months later. Then we'll be asked to fill in a more detailed submission, and it can take 9 to 12 months before you'll get a final answer about whether or not you've got funding. So it's a relatively long and arduous process, and it's not always successful. And some of the important grants have taken sort of 2 or 3 iterations before they've been funded. Research is obviously highly regulated in the UK, so clinical research studies require ethical review. And the purpose of doing that is to protect the rights and welfare of study participants. So if you're asked to take part in a research study, then there will always be information that you need to read and understand. You have opportunity to ask questions, and you'll have to provide informed consent, often written informed consent, although sometimes with surveys that can all be done electronically. And so what are the benefits of taking part in research? Obviously, as a researcher, I'm very pro-research. Clearly, research often offers people an opportunity to learn more about their condition. Lots of people who've taken part in research said that they feel that it gives them a chance to make a difference to other people with their condition. Sometimes, particularly with the early biologics trials, it was an opportunity to access new treatments before they were more widely available in the NHS. But it's also important for us as clinicians, because we know that units that take part in research often have better health outcomes for people. It often improves staff recruitment and retention, and there's some studies to suggest that taking part in research supports better care. So I just wanted to highlight 2 or 3 studies that are running in terms of new rheumatoid, well, some are new and some less new, in rheumatoid arthritis. So I mentioned the biologics register before, and many of you may have been involved in the biologics register and submitted data. So this has been running now for more than 20 years, supported by the British Society of Rheumatology, and the RA register is run from Manchester, and it recruits from more than 250 hospitals across the UK, and has given us loads of really valuable data about the risks and benefits of biologics treatment in rheumatoid arthritis, and also more recently about the benefits of using the biosimilar drugs, so things like the biosimilar etanercept, and showing that that was as effective as the original drug. And then the study that I mentioned before about stopping or continuing biologics treatment for people having orthopedic surgery, that's currently recruiting. And then there's another trial that's ongoing about using oral versus injectable methotrexate in people with rheumatoid arthritis to see if one is better than the other. So if you're interested in research, you know, how do you find out more? I would always say speak to your clinical team, first of all, to find out whether or not they're recruiting for any studies. Also, your GP practice may sometimes send research notifications of studies that they are recruiting to. And I've certainly taken part in a couple of studies that have been flagged to me through my GP practice. Clearly, NRAS will often signpost people to research opportunities, and Versus Arthritis will often reach out for research. You can actually search the National Institute for Health Research, which is one of the biggest UK funders, has something called Be Part of Research, and you can look to see what trials are running in whatever area you're interested in. You can search for rheumatoid arthritis research through there and see which studies are running near to you. So that concludes my presentation. I think we'll be taking all the questions later, but I just want to take the opportunity to thank people who have helped develop some of the research applications that I've been involved in, and a number of different funders who have funded my research. Thank you very much.
Thank you very much, Sam. That was really, really interesting. And we will find the links for both Moose and what was the other one, Periscope, to let you know a little bit more about that, and we'll make sure that we can find those links either on this chat, or we will put it in our research section on our website in due course. But in the meantime, my colleague will hopefully put in a link to our research section on the website. So when we are supporting research or aware of research that's recruiting, we will try and put it up on our website as quickly as possible. So that's a little bit about rheumatoid arthritis and generally rheumatology research. But how on earth do we get families and young people involved in research, and children? That must be even more difficult. So I'm delighted to welcome Jacqui Clinch to share with us some of her experiences of paediatric rheumatology research. So over to you, Jacqui.
Thank you, Claire. Apologies, I dropped out, and hopefully that won't happen again. But if I do, then I know that Sam will will answer some of your questions while I come back in. If my slides can be loaded, please, Anita. Are they there?
Seem to be having a problem with that.
Hang on.
Oh, you just need to add them again. I'm afraid.
Okay, that's all right. I can do that.
We lost the link there. So while you're doing that, Jacqui,
yeah.
Can I just come to you, Sam, with a quick question? So you talked about funding and sometimes how difficult that could be to get funding. Is much clinical research actually privately funded at all? From corporations, I'm thinking, or
so pharma companies will fund research. You may there's charitable funding, there's pharmaceutical companies, there are smaller and larger charities. It's not a well recognized route for funding, but there are probably opportunities to do that. But the other thing I suppose I didn't mention is that clinical research is really expensive.
Yes,
to do.
I was about to say, so I don't think there'll be many, and who knows though, there might be somebody out there sitting on a few million that would like to do some research. Do get in touch.
Absolutely.
But it is incredibly expensive because it's over many months, years, and a lot of people involved, and the analysis and everything is all incredibly expensive. But thank you. Right, I think I've had thumbs up, Jacqui. Your slides should be there now. So over to you.
Thank you. Thank you, Sam, for your really lovely overview and insight into clinical research. I guess my own caveat as well as expensive is they take time. They take necessary time to get robust answers. We're always keen to get quick answers with research. It's frustratingly slow, but that's a necessary process so we get the right answers to inform clinical care. So I'm going to give you a very brief overview of what we do in paediatric rheumatology, and I guess what we now call pediatric and adolescent and young adult, as we're taking the age of a young person into the low 20s, because we know so much more about how their brain develops. And this is an overview of what we do in the UK with our international partners. Clare Payne is one of my colleagues in Alderhay on the Hill in Liverpool, who leads our clinical studies group, and at present I'm Paediatric and Young Persons lead in British Society of Rheumatology. So this is a brief outline, really looking at the structure and how you within the community as patients, partners, families, lived experience, or billionaires, as was mentioned before, might want to get involved. Many opportunities to be shaped by you. So we've got a clinical studies group across the UK, and as part of that, the patient partners and young people with lived experience really inform that. They tell us what they feel is important that we look into, because as rheumatologists and academics, we've got our own ideas, but that's often not what's important to the young people and the families. So patient partners really important, as are the charities, as are the people that hold the purse strings. So that's the NIHR, the National Institute for Health Research, and as was mentioned before, pharmaceutical partners and other organizations. And all of that feeds into our research menu, of which we have to choose some priorities. So the remit of our clinical studies group for young people with arthritis it facilitates research and the funding. We identify the unmet need, where in this vast smorgasbord of ingredients to our speciality, where are the gaps? Where do we need to understand more? We provide expert advice to research proposals. That's our job in the academic circles. And as importantly, make sure it's patient-centered. Sorry, this slide is a bit busy, but this shows you all the people involved with JIA research. So all the charities, the topic-specific groups, and then our international partners, Paediatric Rheumatology in Europe, that's PRES, CARA, which are our North American research partners, the Global Developmental Network that goes across developing countries, a lot of unmet need there, a lot of rich research questions coming from those continents that are really important, and then Printo, which is a big academic body globally. And feeding into that are our own research centres, particularly in Liverpool, London, Bristol. So it's exciting, and a lot of ideas come through this. An example of how this works is you may have heard of a recent biological treatment called a JAK inhibitor, or Jacqui is what it's known as abbreviated. And so we have an awful lot of new therapies coming online, but we need to make sure that they are effective for young people. There's no point in us just saying, oh, a young person is just a small adult. They're really not biologically very different, but also emotionally and how their own body works extremely different to an adult with arthritis. So we can't just go off the data from adult studies. We have to have studies in young people, and that's now in the legal literature. So this is an example of how we involved patient partners and families in devising a study. So we looked at what the study was going to look like. What would the logo look like? Children and families love coming up with different logos for our studies. What was important to them to measure? For me, I might say a certain blood test is an important area that I'm interested in. But to the young person, the family, they don't mind about the blood test. What they want to know is, how effective is this? Can they get to school? Can the parent get back to work? Can the young person have sleepovers? They're the important things that matter to a young person with arthritis or other rheumatological condition. They help with design the information about the study. And then during the study, all our patient partners, and including the charities, make sure that everyone hears about it. Everyone has the opportunity to opt in. Everyone has that chance to be part of, or not be part of, but inform in other ways. And then at the end, it's about getting the results out. How can we say whether this is important? How can people who receive the drug or placebo, as Sam was saying, say that that's important? Are the results important to the young people and families? So every step, everyone is important. We really did this in a large study looking at the research priorities for paediatric rheumatology, and asked many, many families and many patient partners and charities what was important. And then we went to the clinicians and said, okay, as a clinician, what's important to you? What area of research is important from your practice? And then we married them up, and this was published, and this was the aim, to really get a multidisciplinary perspective on it. To make sure we're asking the right questions. And you can see here, this is a very brief top 9 research priorities that our communities said were important and the researchers said. So what's important? Do we know much about anti-TNF and JAK inhibitors in JIA? Looking about early biological treatment, the dreaded methotrexate. Is this still important early on, or should this be superseded by other medications? Looking at juvenile dermatomyositis and different treatments in that, and you can read the rest. These are the trials that people felt, actually, we need to really push these. An area that's very difficult but very important, particularly to patient partners and families, is the element of the impact of disease on well-being, psychologically, physically, life opportunities. And they're very difficult trials to put together, but very important. And that's an area we're really focusing on now. How can we look at quality of life, particularly young adult life, in a young person who's had childhood onset arthritis or other rheumatology disease? And how do you manage it in our adulthood? A busy slide, but really this looked at the trying to marry up what the physicians felt was important in research and what the patient partners felt were important in research. And we very much married on most of them. And again, coming back to number 2 there, understanding, predicting the long-term outcomes of childhood rheumatological disease, physical, psychological, and social. Now, the lovely thing about the tech that's now coming through, that I have to say I still struggle with, is the way that we can really broadcast our research for adults and young people. QR codes, different platforms like the one we're presenting on today, but getting into social media, because that's what young people, not older people like me and others, those young people thrive on those platforms. And if we're going to get our research ideas out and their research ideas back, then my goodness, we need to really be social media savvy, because that's what they look at, that's what they respond to, and they're much quicker to respond than any of us. And we've really learned that, and I hope our research platforms, particularly for young people, is keeping up with the ever-changing current trends. For examples that we've been using, we've been collaborating with the British Society of Rheumatology to really get this lifespan approach to arthritis in young people and up until old age. The BSR have been really involved and increasingly involved in research alongside other charities. One thing we've looked at really with health professionals is saying, okay, how can we improve the quality of care for children and young people? Also working alongside ARMA, saying equity of access. There is not equity of access. There's not the same chances for everyone across the UK. If you live near a big centre, great. But if you live in Cornwall or North Wales or the Outer Hebrides, actually your access to good care and good research is not as good as living more centrally. How can we improve this? And this is part of some of the studies we're really looking at in a qualitative, that's asking everyone's opinions and subjective, to quantitative, how can we measure it? So this is an exciting area we're looking at in JIA. We're also got, like Sam was saying, got the biologics register that's just been rebranded, working across the charities with the biologics register to make sure that we keep all the safety data and how effective the new biologics are, because my goodness, they're coming in thick and fast. Something close to my heart, working with NRAS and others and the GOS team, raising awareness of the need for mental health support services for young people who've got a diagnosis of arthritis. We're very good as health professionals saying, oh, good news is your arthritis is well controlled or you're in remission. But actually, we're not so good at understanding the mental impact on a young person who actually has fallen off their peer groups, is not getting to school as often, and where the pain's still there, despite the doctors and professionals saying actually the arthritis is well controlled. So understanding that better. And that was a real learning thing for us, a learning curve for us, because we asked nearly 300 young people and their families what was important. And the key messages loudly heard: there's a significant impact on a child's mental health, significant impact on the whole family, and we really need to follow this through. And I'm glad to say that we've had some parliamentary lobbying with some success, that we're taking this forward. We'll keep you briefed on that within the NRAS family. So a final thought, apologies, this is the wrong text colour. I think for paediatrics, young adults and adult rheumatological research, every person deserves the opportunity to take part in relevant and well-conducted research. And I would urge everyone listening in to consider that and to look at all avenues. It's an enriching experience for many, many people and invaluable for us. And every healthcare professional also deserves the opportunity to take part in relevant and well-conducted research, because that keeps our learning fresh. And it's important to hear from everyone in the community what's important to them to get right. So thank you for bearing with me with my slightly dodgy link. And over to you, Claire, for any questions.
Thank you so much. And we've been getting lots and lots of really fantastic comments and questions in the chat. So thank you all for keep them coming. We will be keeping an eye on them as you like. Lots of praise for both really thinking about not just the physical impact of an inflammatory autoimmune condition like JIA or RA, or PSA. Somebody else has mentioned psoriatic arthritis, and of course a lot of these studies will cover inflammatory arthritis generally, not just specifically RA, but of course we're talking mostly about RA today because we're NRAS. But really lovely to know that there is so much more focus now about quality of life, about the impact on emotional health and mental health. We've just done a big survey on stress and how stress can, really manifest itself in a physical format with exacerbating symptoms, etc. So, there is so much research going on. But going back, I've got quite a few questions that were pre-submitted before this evening as well. So I'm just going to crack on. It might be, a bit quick fire, but we'll get through them. Interestingly, there is quite a few questions about funding, and I know you talked a little bit about this, Sam, already. But has Brexit, has COVID impacted the funding generally in the UK for research? So, where we might have been getting European funds before, has that been impacted? And of course, the second part of that question, COVID, most research came to a grinding halt for a while there because everything was focused, probably quite rightly, on COVID research. And has it been difficult to get that back up and going? And has some of that funding that you would normally have been able to access disappeared or reduced? So who wants to go first on that one, Sam?
Sure, shall I go first? So in answer to the Brexit debate, Brexit's clearly had a big impact on scientists coming to the UK. It has made it harder to access some, but not all, European grants. There are still, and the government is working quite a lot on something called Horizon 2020, which is about how the UK accesses research funding. But it's certainly undoubtedly had a big impact on scientists and exchange of ideas from that point of view. In terms of COVID, you're absolutely right. A lot of non-COVID studies stopped during the pandemic, or we changed ways of recruiting people to research studies. But equally, there were other studies that actually were done because of COVID. So, particularly recruiting people, for example, to vaccine trials and that sort of thing. I think we're only over the next couple of years going to see whether or not there's a cutback in funding for non-COVID research. Certainly, COVID research was rightly prioritised initially during the pandemic. But actually, COVID also did quite a lot to invigorate the clinical research community. Yeah. So if we think about the vaccine studies, that some of the best recruiting sites were not hospitals that were traditionally, research active or the places that you'd necessarily think of. And in fact, it's going to be really important as we go forward that we build on, continuing to use some of these centres that actually didn't used to be big research active centres, but were really good at getting people into clinical studies, particularly, as I say, for the the new things like the recovery trial, for example, about some of the other treatments for COVID were recruited from across the country, and COVID did make people look at exactly what expertise was needed and what paperwork was needed, and there were some things that actually COVID helped to kickstart a discussion about.
Yeah, and I think as well that it invigorated interest in research in the general public. I mean, absolutely. Probably most of us listening may have participated and put our info. Actually, Sam, could you just move your mouthpiece down a little bit? We're getting a little bit of feedback. That's probably perfect. But it people that would never normally be thinking about getting involved in research now were because of COVID. What about you, Jacqui? What was your response to that question?
So from a Brexit point of view, I don't think we know. Apart from, as Sam says, there are many international researchers who I think it's more tricky to get across. And from a grant access, again, as Sam says, there's a lot of work behind the scenes to try and really keep some channels open or reopen channels. Certainly, the majority of us think it was a real backward step, but we're trying to work with it. COVID, I think, is fascinating. So paediatric rheumatologists and paediatric infectious diseases suddenly came into our own with COVID because we were using the drugs for a condition called HLH or MAS, which it was very similar in its and how it worked biologically to those people on ITU who are so sick with COVID. And so the drugs we used were used in the trials that Sam mentioned and others to treat people who was very sick with COVID. And so actually, from our point of view, our research almost lit up. And the other really positive thing about it was it brought together research groups who often, a downside sometimes of research, people work in silos. Actually, what it did was really bring together researchers who were looking at slightly different diseases, but then found a lot of similarities. And I think there's been a richness to some of the research that's followed. So I think COVID, as ghastly as it was for academia, there were some good things that came out of it, as well as the vaccination program. Unfortunately, it also did harden some of the conspiracy theories that I think are going to take more time to undo about research generally. And we're seeing that sadly with other vaccinations in young people, is that some people who would normally have had the vaccines, measles vaccines, etc., actually have decided not to because of their fear of the COVID vaccine. So there's a lot of messaging, communication that we need to get right.
Yes, indeed. And actually, before I forget, you're talking about the COVID vaccines. We've just heard today that the autumn boosters for those with who are immunocompromised, including children, those over age 65, etc., the flu and the COVID vaccine is being brought forward and will start to be rolled out as of the 11th of September. It was going to be early October, so I thought I'd better mention that before it goes out of my head.
Yep.
Other questions, quite a lot of questions about because rheumatoid arthritis affects mostly women up to a certain age, but it's 3 times as many women as men. I don't know whether this is I've seen no evidence of this, but is it a feeling that you might have that if it was a men's condition, it would get more focus, more research? I'm not sure.
I haven't seen any evidence for that, I have to say. I don't know whether, Jackie, you feel any differently about that?
So with children, no, I've not. From our point of view, JIA, juvenile idiopathic arthritis, we don't tend to see the sex difference until 11, 12, when we then absolutely do see girls more than boys. No, I don't think I've seen any change with the different sexes.
Yeah, and with research, it's nice to see that some of the research now moving into young people as well, transitioning into adulthood. Is there any specific research going on with adults with juvenile idiopathic arthritis? Because often what we're finding is people are recategorized as having RA when actually they haven't. They still have JIA, they've just brought it into adulthood. And are you aware of any studies that are going on specifically for those adults who might be in their 40s and 50s but still have JIA?
Such a big topic. This is a whole topic on its own, Claire. We absolutely know.
On that.
We absolutely know that childhood onset arthritis is different to RA. We absolutely know that young adults, older adults who had childhood onset arthritis, it is different. So and it's really important not to label it RA. And that message is still coming through. From a research point of view, there's a lot of research looking at the ages 18 to 30, because that's an area that's been barren. We've just thought that the arthritis finishes at age 18 when they're no longer under me as a paediatrician and may start again when they're under an adult rheumatologist. There's much more lifespan approach, which is right. There is research going on to well-being, quality of life, something close to my heart, with persistent pain and fatigue in young adults with childhood onset disease. And we're also looking at getting proper figures on actually how many adults with arthritis had it starting in childhood, because it's far, far more than we used to believe. It doesn't burn out in the majority of cases. So what we're doing is scoping. The research is scoping the numbers that still have arthritis, and also impact on well-being, particularly mental and physical health. Yeah. And I'm very happy to give the links to Anita and you to share on the NRAS website, along with all the other research.
There's quite a lot of chat at the moment. That we've got somebody, Gail has just mentioned that she's 55 and had systemic JIA for 50 years, and so it's good to have that starting to be talked about and looked into. Quite a lot of chat as well in comments in the chat, but also we had got a question submitted before this evening, about research into menopause, perimenopause, and if there's any research going on. And I'm delighted to say that I'm actually currently working on a survey with a number of research nurses into that specific question, because how perhaps early onset, or not early onset, but going through perimenopause and then into the menopause can be a trigger, or and how it's being picked up at early on in that stage. So please do keep in touch with NRAS, because I'm hoping within the next sort of month there will be a survey going out asking you these specific questions about how your inflammatory arthritis was exacerbated or made worse, or was an onset of your condition was triggered by the menopause, and we want to find out about what your symptoms were, etc. So watch this space for that. But are either of you aware of any other studies that have been going on regarding either JIA, adult JIA, and RA linking with the menopause?
So there are none. It's a quick answer for me, because there are none that I'm aware of from a JIA and menopause. We absolutely know, though, in some types of childhood onset arthritis, and there are many different types, going through puberty affects it. Not in everybody, but that change in estrogen particularly has an effect on some young people with their arthritis, but I'm not aware of it with menopause. But as we get the numbers and understand how many people with JIA are going through the menopause, then certainly we can look at that.
Mm-hmm. Sam, any of your colleagues looking into anything regarding menopause?
There's some research about early menopause being one of obviously many different risk factors for rheumatoid arthritis. We know female sex hormones obviously have quite an impact on disease activity in rheumatoid arthritis, if we think about the effects of pregnancy, the effects of breastfeeding on arthritis. There were a couple of trials many years ago using HRT as a treatment for rheumatoid in addition to other things, and it didn't seem to be particularly effective in terms of joint pain, but you know, those are old trials.
Thank you. There is somebody who suggested that perhaps should GPs not be routinely screening people going through perimenopause or menopause for rheumatoid arthritis. So I think that's would be an excellent thing, but I'm not sure it will be something that will happen quickly.
No, and I think, and to be fair to GPs, I think that's really tricky. If we think about one in 5 people will have osteoarthritis, and 0.8%, so about 1 in 100 people have rheumatoid arthritis. It's very tricky for GPs to be able to pick that out, particularly in early stages, as people will know.
Talking about primary care and GPs, is there much collaboration when it comes to research between secondary care and primary care? Do you see much of that, or should there be more of that?
Shall I take that first, Jackie? Yeah, absolutely. At Keele, in our own research centre, we are a centre for primary care research, so quite often as the secondary care rheumatologist, I'm in a room full of GPs. So there's quite a lot of collaboration there within between primary and secondary care, and other research units will be the same. And usually when we think about recruiting for research, clearly we can go to GP practices to do that. And there's often quite a lot of collaboration direct with GPs and what's known as the clinical research network to think about research studies. I think it depends on the nature of the study and the question being asked.
Yeah. I'm just having a quick glance through some of the other questions. Sorry, go ahead, Jackie.
Oh, just very quickly, we work with Keele. Keele is the centre of excellence for all things primary care, and we're currently looking at all young people presenting to their GPs across the whole UK with musculoskeletal pain. So it's a massive study, and Keele's the only place that we can link in with to do that.
That's great, thank you. There was a question, you may not be able to answer this, I don't know, but it was regarding the study that you talked about, the what was it called? Oh, I've lost it now. The periscope. With the issue is, even sometimes when there is evidence about stopping methotrexate or not stopping methotrexate before surgery, depending on the type of surgery, sometimes there's a conflict perhaps between what the rheumatologist is saying, what the surgeon is saying. So somebody has shared that in the chat, that my rheumatologist said to carry on with the methotrexate and her biologic, but the surgeon said he wanted it stopped 2 weeks either side. And of course, the fear is then of a going into flare when you're post-op. And that's a genuine concern for a lot of people undergoing surgery. Is there any preliminary results from that periscope study at this moment, or is it too soon to say?
No, that's only just started recruiting it, and the scenario.
Oh, I think
the scenario that Sue's put in the chat.
Oh dear.
So no, there aren't any preliminary results. But the scenario that Sue's put in the chat is absolutely the reason for the study being done, because surgeons are very concerned about risks of treatment, and obviously as rheumatologists and as patients, clearly we want to keep people's RA under good control, but it's a difficult one.
Somebody has mentioned, I mentioned it already, about psoriatic arthritis, and being the Rheumatoid Arthritis Society, of course, we're regularly talking about RA, but there is a lot of crossover between the two types of inflammatory arthritis, and probably similar in children that might have psoriasis as well as JIA. Are there any specific studies that you're aware of, in particular about PSA, or Jacqui's nodding?
So what we've learned as a community is that we've always subdivided, and we've subdivided really because we understand patterns of disease. So psoriatic arthritis, and these apply to children, same as systemic onset JIA, or what used to be called Still's disease, polyarticular, whether it's rheumatoid factor positive or negative. And from a research point of view, there is research in all these areas, many research in young people and in adults. So very much look on the research forums, and I say we'll list all these so everyone can look at different research opportunities. What I would say is that often, from a quality of life and a research outcome, patient-related outcomes, reported outcomes, there's a lot of similarities between having extremely stiff joints in the morning. It doesn't really matter then whether it's psoriatic or systemic or others. So I think there's different researches, but there's also an awful lot we can learn from different disease subtypes with different people involved. So it's lumpers and splitters with all the research. But yes, many research projects, and I'm delighted they're going across the lifespan, many of them now, rather than this kind of false age cutoff.
Yes, yeah, I think we're seeing a lot of that. But some brilliant questions coming in. Amazing that we've got such a widespread of an audience. I did see we've got somebody joining us from Missouri in the US, so welcome. You're very welcome. We've been talking mostly about research, of course, in the UK, but a lot of studies are global, and again, we'll be when we have opportunities for people to participate in research that either we're supporting or actively involved in, we will be putting it up on our website. So there is a link. If you go onto the NRAS website and just do NRAS Get Involved Research, you will find the latest opportunities there. But also when we have supported research, we do like to tell you about it afterwards. It might seem an awfully long time later before things are published, but I'm delighted to say we've been working with Sally Fenton, a research on a project called Mission RA, and some of that has already been published. So I shared a link earlier with my colleague. Hopefully she'll be able to pick that up and pop it in the chat. But there is lots of information about the latest research when we have it. We will put it up on our website, so do check that out. I'm afraid we've run out of time with my wonderful guest. We could talk about research all night, I'm sure, but I'm sure after a busy day in clinic, perhaps for both of you, you want to crack on. So just a few reminders to our audience. On the next NRAS live broadcast will be about the new guidelines issued by the British Society for Rheumatology on treating RA during pregnancy. So that's on the 27th of September, NRAS Live. Again, you can find the information on our website in due course. I can let you know, I wasn't sure whether I was going to be able to tell you this this evening, but I have been given the okay, that on the 10th of September, we've been fortunate to have the Radio 4 charity appeal for NRAS. So on the 10th of September and again on the 14th of September, we're very privileged to have broadcaster Kirsty Young will be voicing our charity appeal. So please do listen in for that, but also most importantly, share the links and share through your own social media contacts. Just a little reminder about our SMILE program, Self-Management Individualized Learning Environment. It's free. Our latest module was on exercise, and there's some lovely little taster sessions about different types of exercise you can do. Again, it's free, and yes, in Missouri you can also join in on that, and you can work through the modules at your own pace. And all of our NRAS live broadcasts like this are recorded. You can watch them back. If you joined us late and you missed the beginning, you can go onto our YouTube channel and watch them back. And last month's one was on foot health and orthotics. So best foot forward on that one, and you can watch that again. If you think there's a burning topic that we haven't covered on NRAS Live, please let us know. We want to deliver what you want to hear. So if there's a particular topic that you think would be worthwhile, we've had fantastic opportunities to have guests like Jacqui and Sam join us. We're well known across the world of rheumatology. So please do let us know if there's a topic that you'd like covered. And likewise, for any researchers out there or colleagues of Jacqui and Sam, if there's a way that we can help and support, we're helping a raft of various different types of research going on at the moment, where we have a wonderful reach to our fantastic audience that we have here and through our website, etc. So we're very much keen to continue to support as much research as we can. I think that's all my little notes that I had in front of me. Oh, yes, there was one quick question I wanted to come back to before I let you go, Jacqui and Sam. Socially deprived communities and communities where perhaps English isn't their first language or it's not within their culture, what can we do better to engage people in research, because they're not truly represented in current research, especially from the South Asian population? It's difficult to engage, and from the Black and Caribbean communities. Are there any tips as to how we can maybe make it more accessible for people from a variety of communities to get involved?
Just very quickly, from my point of view, we're working very closely with our with Banner, which is our Young People's Voice, and Armour. I think to involve them, we need to understand, and culturally there are lots of different viewpoints. So I think we need to lose a little bit of our own arrogance, if that's not too strong a word, with saying, oh, this is research is important to you. We need to actually have those voices on our research panels. They need to be part of what's informing our research questions, because then it's important to them. And I hope we're starting to move that way.
Right, thank you. And Sam, the final word from you.
I'd absolutely agree. You know, we increasingly recognise that there are some populations that are underserved with research, and there are different ways to engage, whether that's engaging with different community groups and going out to people in different ways to talk about research and why it's important.
Thank you very much. And on that note, I would like to thank everybody for watching this evening. As I said, you can watch this back on our YouTube channel. But a huge thank you to my colleague Anita, who's been in the background answering some of your questions and comments in the chat as well, and making sure we were broadcasting and not just talking to ourselves. Thank you for everybody that's stayed on and watched the whole thing. I can see there's been a number of people there. Do share the links with friends that you might know might have missed out. But a huge thank you to Dr. Jacqui Clinch and Professor Sam Hider for joining me this evening, and hopefully we'll see you again in the future. Maybe next year we'll do an update on where we've come from this year on research. Thank you very much and good evening.